I want to welcome Dr. Timothy Lopez here tonight, who was born and raised in Albuquerque, went to UNM Medical School, and then did his residency at Bay State Medical Center in Springfield, Massachusetts, followed by a fellowship at the University of Texas, MD Anderson in Houston, Texas. And after that, he moved back to Santa Fe. He and his wife now live in Santa Fe, and they have 3 grown children. Timothy Lopez actually founded the New Mexico Cancer Care Associates and practiced there since 1990. After a sabbatical in 2017, where he toured around the country and Canada, he came back to work part-time in his old group. He now works 2 days a week at the Los Alamos Medical Center's Northern New Mexico Cancer Clinic. And we're very happy to have him there. He's also been very active in many community services, and he also loves the outdoors, as he said, in this great, beautiful state of ours. So let's welcome Dr. Timothy Lopez.
Can you hear me? Great, thanks. Well, I'm really excited to be here with you all, and I really want to thank the Los Alamos Council on Cancer for having me. And it's a real honor and privilege to be here tonight, as well as to be working and serving in your community. So, really, I've seen Los Alamos patients over the years in Santa Fe, but it's really nice to see patients here in this community and to serve them here. So today, I am going to do a sort of a broad brushstroke about a concept called precision medicine. And I went to the American Society of Clinical Oncology meeting in June of this year, and was very fired up and inspired about some of the work that was being done. It was the first time that the term precision medicine had been used. So I thought we would start by talking about objectives of tonight's visit, and then to go from there. So, I'm not sure which way to look. So I can actually see my slide there. But I have a pointer. So, I'd like to explain what precision medicine is, the challenges and limitations of our current diagnostic techniques, and then I would like to review the history of how we got to where we are with cancer treatment as it applies to precision medicine. Next, we will provide examples of how precision medicine works in everyday life, using examples of pancreatic cancer, breast cancer, lung cancer, and lymphoproliferative disorders. Finally, we'll sort of address the challenges of this as well as the opportunities for the future. So, the National Institute of Health defines precision medicine as an emerging approach for diseases and treatment that takes into account individual variability in genes, environment, and lifestyle for each person. So it's really basically giving the right treatment for the right person, irregardless of their diagnosis. So, and we'll explain that further. The whole theme of this year's meeting, the annual meeting, was expanding the reach of precision medicine, and that was at our June conference. And I should be honest, I was able to obtain these slides from that conference. So, most of these slides are not original. These are slides of other presenters at the conference that I was given permission to use. So the main premise of precision medicine is to connect specific medical treatments to individual characteristics, the right treatment with the right intervention. This entails pathology, the tumor type. The primary thing in precision medicine has been the genomic sequence, the mutations in the individual cancer targeting the consequences of those mutations from that cancer. But other things come into play. Transcription of the DNA to RNA, the RNA going to proteins, the proteomics, the metabolics, the whole chemistry of the cell cycle, glycolysis, the pharmacogenomics, how the pharmaceutical agents interact, in particular people and their cell types. And then finally, the microbiology of the system, so the microbiome. So it's not just genomic, but most of precision medicine, I'll be honest, is based on the human genome. And that's actually we'll talk about that as far as challenges and opportunities. That's some of the biggest criticism, is that it's maybe too specific and not adequate. But let's get excited. So historically, back in the 70s, there was one size fits all. We had very limited cancer treatments, and we treated everything with what we had. And it was just doing the best you can with the type of chemotherapy that we have. And most chemotherapy is anti-proliferative agents, so it works on cells that are dividing, works on DNA reproduction. The first targeted agent we really had came in the 70s when Dr. Jordan Jensen discovered the estrogen receptor on breast cancer cells and a drug specifically called tamoxifen at that time, which inhibited estrogen at the binding site. So it was an estrogen-like molecule that would bind to that receptor and prevent estrogen from stimulating the cancer. So that was really the first of our targeted agents. Since then, there's been a lot of advances. And I completed my fellowship in 1990. I spent 2 years working in a molecular hematology lab, doing molecular biology. And a very exciting thing happened just as I was leaving fellowship, and that is the Chinese were treating acute myelocytic leukemias with transretinoic acid. And in those days, we didn't really have any great treatments for acute leukemias, and patients with this APL subtype frequently died during induction and bleeding. But the Chinese, with transretinoic acid, were able to observe the cancer cells differentiate into normal cells. And they couldn't understand why, but it was a phenomenon that everybody got really excited about. And everybody knew that APL had a 15-17 chromosomal translocation. Part of chromosome 15 went to 17 and vice versa. Well, they took the information from the bedside and went to the bench, and they found that the retinoic acid receptor was on chromosome 15. So it kind of created a really substantial understanding of natural history by replacing retinoic acid. Of interest, only transretinoic acid works in that disease. Cisretinoic acid that people use on their skin and things like that does not work. So that has to do with the chemistry of the molecule. It's just some trans for those chemists that are in the room. But that was a very exciting time, and that was a leap forward in the whole approach to treating a genomic result of the cancer. Rituxan was developed in the 90s, and that is a drug targeting B cell CD20. It's a surface antigen on the surface of a B cell, and it's become a mainstay of treatment of all of our lymphomas and B cell leukemias. Herceptin story is another very exciting story of I knew that there was a subset of breast cancer patients that had a very poor prognosis, and they happened to express this human epidermal growth factor and called HER2. Nu was the mice name, so the two people that discovered that simultaneously, they kind of had to combine the name to HER2/Nu. So one group found HER2, another group found Nu. It was the same molecule, so then they combined it. Well, Dennis Schleiman at UCLA, through his persistence, was able to develop an antibody against that HER2/Nu molecule, and that has revolutionized the treatment of HER2-positive breast cancer. So it used to be a very poor prognostic breast cancer, and now with these new treatments, it has a much better prognosis associated with it. This magazine here is called The New Animation of Organ Cancer. This is the story of Gleevec, which is another exciting story in a disease that also has specific chromosome change, the 922 translocation of chronic myelogenous leukemia. And we all knew that there was this protein that, called the BCR-ABL protein as a result of that chromosomal translocation. And it was a tyrosine kinase. And we also knew that if you translocate that little splice of DNA into non-cells, then it can cause CML. So we knew that that was definitely the driving mutation of causing that disease. When he convinced Novartis to develop a drug to turn off that tyrosine kinase and make it non-expressive. And that was the story of Blockade. He hit a home run with that drug. And so now there's several other tyrosine kinase inhibitors that work, but we found a 90% response rate with patients with CML, and this was a treatment that we didn't have such great success with in the past with our treatments. The reason why it was such a big thing for Novartis is there's not that many patients with CML out there, so it wasn't going to be a big moneymaker for the drug company. But it kind of proved the whole concept that you can actually take a molecule, target it, and get a good outcome. At the same time, around 2001, the Human Genome Project was launched to sequence the entire human genome, and that allowed a whole lot of opportunities to understand where different mutations occur in our DNA. As you know, that's since been done. Then we have a lot of other molecules that have been developed since. Some of the exciting things are this epidermal growth factor receptor agents that came out in the early 2000s, especially the Japanese, where they were pioneered this. And they found that these primarily Japanese women that were non-smokers were given these oral agents that target this receptor on the surface of the cells, and they have a very high success rate for their lung cancers. And that's really kind of changed the treatment of lung cancer. And then finally, in malignant melanoma, using these BRAF inhibitors, you can use one individually, and then they started using them in combination, having a very high success rate in BRAF positive melanomas. Though not all melanomas are BRAF positive, melanoma can often be a very difficult, in stage 4 setting, can be a very difficult disease to treat. But when it's BRAF positive, one can have pretty high success rates in treatment with these new target agents. So, that's kind of how we got to where we are. What happened last year was that for the first time the FDA approved the concept of treating any solid malignancy that has a particular mutation with an agent that targets that mutation. So that's, let me use my little pointer here. So example, the HER2 thing I just told you about, in breast cancer, is a single agent. It has a response rate of 50% by itself versus other chemo drugs with maybe 32%. Now with chemotherapy, it has a higher response rate than combined. Well, the HER2 is also expressed in some stomach cancers, salivary cancers, colon cancers. It can be really expressed in other cancers. It's not a lot of them, but it doesn't have quite the same response rates as it does in breast cancer. With salivary cancers, it's actually very positive. But the big problem that we're finding with these target agents is when you span across multiple different tumor types, that molecule may be more specific, maybe more successful in one particular tumor type than it is in other tumor types. This mutation up here, the NTRK, is found in a lot of different tumors, but we don't really have a good targeted agent for that just yet. But the whole idea is in May 2017, New England Journal, the first approval of an agnostic cancer site when a biomarker defines the indication. And so, I'll tell you more about that. So, this is the same thing I was just telling you. The BCR-ABL is a tyrosine kinase. Well, c-KIT is a very similar tyrosine kinase, and it's seen in other tumors, such as a gastrointestinal stromal tumor, or a GIST tumor, we call it. Well, the gleevec, or imatinib, has about a 40% response rate in that tumor, as opposed to 76% response rate in CML, the initial studies. And then in the salivary gland tumors, we just saw the HER2, c-KIT can be expressed, but it was a negative study, so using the gleevec did not work. So there is a lot of heterogeneity across the tumor types. Here's an example of the BRAF. In melanoma, 55% response rate if it's BRAF positive. In lung, it's down to 33. And then, but it's very high in brain tumors, gliomas. In colorectal cancer, it's only 5%. So you may have this driving mutation that you think is driving that particular cancer, but you may not see the same response rate across tumor types. That's the message I want to share. The next thing I'd like to talk about is the molecular testing, because there's been some evolution going on there with how we test for these mutations. There's been some success, much promise, much criticism, and much hype with this whole precision medicine or targeted treatment. Some of our biggest challenges have to do with who to test, when, what sample, how to order it, and which test. And for a community oncologist such as myself, there's a lot of different options out there on how to perform these tests. One has to interpret the results, recognize the germline variants. Just to explain what germline is, that means it's inherited, it's part of your inherited chromosome of nature, as opposed to a somatic mutation, which is seen in the tumor only, not part of the germline. And then one has to, once you figure out, after you've tested them, how do you get the drug? And I can just tell you this today, I just received a refusal. A patient came in, and we had done one of these molecular profiling tests, and her Blue Cross Blue Shield insurance denied that test. So the big question is, unfortunately, we didn't discover a really specific mutation to go after with that, but then the next step would have been to obtain the investigational drug or the off-label use of that insurance company. So this is all going to be a challenge. And there's the issue of consent and then the financial issues. Some of these new targeted agents, unfortunately, because they're new, are extremely expensive. So it can have a big impact on our society as a whole. Another concept here has to do with genetic damage that occurs and what causes cancer. So in this slide, we're showing multiple hits. So here's a mutation, boom. You go along, hit a second mutation, boom. And then third mutation, boom, and one has cancer. Well, what happens, this continues. The cancer itself can continue to mutate. So we can have what we call genetic heterogeneity, what a cancer is. So what we found, for example, that when a breast cancer may have certain mutations, but then the metastases of that breast cancer may have additional mutations, so that tumor itself kind of changes its behavior. Or for example, an estrogen receptor positive breast cancer may turn estrogen receptor negative at a later point in time. So the type of testing we have is germline testing. And the classic examples are for hereditary breast cancer. So the breast cancer gene 1 or 2 used to be drawn by blood, and it was a gene mutation we could test for. Now what's happened is that in these big molecular next generation sequencing, that gets thrown in the milieu. So it's a 50 gene assay or 100 gene assay, and they can test for these germline testing with the next generation sequencing. It's kind of replaced the old standards. So panel testing is actually becoming more routine, and we don't have that many hereditary germline mutations to test for. It's really, there may be 10 different mutations that we can actually test for hereditary cancers. The Lynch syndrome and colon cancer, neuroblastoma in kids, there's just not that many out there. The majority of these tests are done on the tumor itself. So with the colon cancer, you take the piece of the colon specimen, you send it to the lab, and they take the DNA, isolate it, and then test for mutations with this big next generation sequencing panels. There's just a big broad scope of different mutations they're testing for, trying to find out what mutations that tumor has. This whole exon sequence, let me go back. Then on the horizon may be this whole exome sequencing on the horizon. And I'll be honest, I don't know a whole lot about that. did molecular biology a long time ago, but I wouldn't say that I'm completely current on some of these newer sequencing techniques for the tumors. But basically, the idea is bigger panels of genes distinguishing true somatic alterations can be problematic, because you can find lots of different mutations within a tumor, but you don't know which is the driving mutation, what's making that tumor want to grow or metastasize or do the bad things that it do. The nice thing about these tests, when you take the tumor, oftentimes you don't really need a consent. I mean, you usually talk to the patient because you can involve insurance companies and getting them paid for when you're doing these molecular tests. But it's not absolutely consent. Now we can actually test your blood. So they draw your blood and they try to isolate the DNA from your blood from the cancer cells. And this can be done for two reasons. One, diagnostic, to see what that cancer's mutations are. And two, it can be done to monitor your disease progress. So when you have a patient with malignancy and you treat them with a certain substance, you can sort of do a liquid biopsy afterwards to see if they're in a complete response in that regard. It's still a little bit controversial, and again, these molecular profiling tests are a little bit, they're expensive because it involves molecular biology. So you send them to these outside labs, and so I haven't hit the prime time as far as routine use for follow-up on cancers. But it is a recent, sometimes you get a lung cancer, for example, that you can't get a biopsy that's in a too dangerous of a location. You just can't do the molecular profiling. Well, the next step would be to do a liquid biopsy and try to find the data that you need to make treatment recommendations. The half-life of the DNA is very short, and the finding of the cancer DNA is like looking for the organ stack. But nonetheless, it is a technique that's being developed, and it's pretty exciting. So now I'm going to transition to what does a doctor like me do with a patient. And this is an example of a patient in April this year. It's 49. She had stage 4 pancreatic. Oh, who to test? Most of these are being done on stage 4 patients who have exhausted regular treatment options and you're looking for other treatments. But I can tell you, we're now testing all lung cancer patients right out of the chute for these mutations to know what's the best optimal treatment, even in the adjuvant setting. But most of these patients that are going to pancreatic cancer, we don't test right out of the bag. We would treat with traditional treatments, and then if you're running out of options, you would look for a molecular profiling to find out. So she was unresponsive to FOLFIRINOX, so they sent it for molecular profiling, and they found this result. She did have the BRAF mutation, which I told you is common in melanomas. She also had the B10 mutation and the TP53 mutation. You do not have targeted agents to treat either one of these mutations. So we know the mutation exists, but we don't really have a drug to treat it. She also had some other findings. These have to do with the use of the checkpoint inhibitors, the immune therapies, the PD-L1 and the PD-1, the Keytruda and the Opdivo, the PGC, the TV advertisements. We're going to talk about that in a bit. So these would say she's probably not a candidate for that. So what do you do with this information? Well, this is a community-based tumor board, so it gets sent to them, and they come out with a recommendation. They say, we had an opportunity to discuss the case of your patient in our tumor board on April 6th. Using the information from this profile, this patient has a BRAF mutation, which is a known pathogenic variant. While most of the data is in melanoma lung cancers, there was a study in the New England Journal that used BRAF-directed therapy for non-melanoma patients with this variant. Therefore, they recommend that the patient receive BRAF-directed therapy. In this case, the patient had a 20% reduction in her tumor sum and it persisted for 7 months. So actually that was that one case. So then they said the team recommends BRAF. So someone like me, if that was my patient that I sent out and the oncology tumor board comes together and comes with this recommendation, it gives me more ammunition to go to the insurance company and say, I'd like to use durvalumab in the treatment of this patient, which is not FDA approved for pancreatic cancer, but it would be indicated in that particular patient for her particular mutation in her tumor. So that's kind of interesting. I'd like to move on to breast cancer, pancreatic cancer, and just talk a little bit about what we know about breast cancer now as to before. So now we really have a better idea of the different types of breast cancer that we treat and where targeted therapies roll. So we have basically 4 types of breast cancer. We have the 50% for the favorable luminal A. They have the estrogen receptor. They have a low proliferation rate, and they have a very good prognosis. So that's 50% of breast cancers can be treated with hormone therapy alone and do not need chemo. Luminal B have a little bit higher proliferation rate, a little bit less hormone receptor positivity. They're about 20%, and they have a worse prognosis compared to luminal A. But they still respond to hormones, but they may evolve more quickly into causing problems. We talked about the HER2, which is only 15% of invasive breast cancer. It's estrogen receptor negative, and it has a high proliferation rate. It always had a traditionally poor prognosis, but I'm saying with these new drugs, actually the prognosis has improved a lot for these patients. And then finally we have what we call the triple negative breast cancer. No hormone receptors, no HER2. And this is where we really need to make progress, because we don't really have optimal treatments for that, and we're sort of left with our traditional chemotherapy agents. But that's kind of what we know, how we're involved in the term of individualizing treatments for particular patients. So we have these endocrine therapies that have been developed. We have HER2-directed therapies, there's many of them. And now, the newest thing are these CDK4 inhibitors and mTOR inhibitors. And what they've done is they've taken the estrogen receptor positive cancers that have no longer responded to hormone therapy and become resistant. And it's kind of given them a second life, because by targeting that mTOR or the CDK4, all of a sudden those cancers become responsive to hormone therapy again. So you use these drugs in combination with hormones. So it's kind of created some longevity for our stage 4 breast cancers that we didn't have before. When we had to move on to chemo, now we can use these newer agents to allow us to use hormones again. Okay, now I'm going to talk about the concept that's difficult to explain. So I'm going to try to use this, we're kind of moving into the lung cancer thing, and I'm sort of addressing some of the highlights of all the TV advertisements that people see with Opdivo and Keytruda and all these new immune therapies called the checkpoint inhibitors. And so I just kind of want to give you some background of where it all started. Back in 1984, we understood the T-cell receptor gene and led to the cloning. This is sort of the holy grail of immunology, and this really has to do with programmed cell death. So the T cells were able to use this PD, programmed death molecule to allow the cell to die. Well, it's sort of created a pivotal breakthrough for cancer immunotherapy using these checkpoint inhibitors of PD-L1 and PD. So PD-1 is on the T cells. PD-L1 is the ligand on the macrophages. These are the immune molecules. And then the CAR T cells, it's hard to explain, but that's a chimeric antigen receptor activated T cell. You take these T cells and you grow them, and they're targeted to a particular lymphoma. Right now it's only used for lymphomas and leukemias. But you may have read about the Pennsylvania study with all these children with refractory acute lymphocytic leukemia, and he treated them with his CAR T cells, and he had a 90% response rate. These are kids who had not responded to anything, and all of a sudden 90% of them responded to this infused T cells to treat their cancer immunologically. So what we don't really have, and this is the point I want to make across, is that we talk about estrogen receptor. Well, you know you want to target that estrogen receptor. But we don't have a good marker to know which lung cancer is going to respond to the checkpoint inhibitor and which doesn't. And there's a lot of work being done right now to try to discover that. So these are different things. Patients that have a high mutation load, tumors that have a lot of different mutations, they tend to respond more to the checkpoint inhibitors. Patients that have this MSI instability, that means that their chromosome DNA is kind of unstable, microsatellite instability. If they're very unstable, they tend to have a higher response rate to the checkpoint inhibitors. Patients with immunohistochemistry, you can see the PD-L1. This has actually turned out to not to be such a great marker. We thought, like one of the lung cancer treatments, Keytruda, is only indicated of PD-L1 positive lung cancers. But it turns out that that's not actually a great marker for when Keytruda works or doesn't work. So, but that is a thought. And then finally, we have tumor inflammation signatures. So what I'm trying to explain is that with these checkpoint inhibitors, which are used now, not just in lung cancer, but they're used in bladder cancer, head and neck cancer, and they will be used in other, they're more and more melanoma. They're used in kidney cancer. So we're using these checkpoint inhibitors, these immune treatments for a lot of different cancers, but we don't really have good markers to know when the immune therapy is going to work or when it's not. So it's it's almost like chemotherapy where you kind of treat everybody with the same, hoping that you're going to get a response in some. But I think that's coming. I think we'll have a better idea to know who to treat with these immune checkpoint inhibitors or not. So, the take, actually, we can delete that slide. This had to do with what we talked about, the concept of heterogeneity. You can have genomic heterogeneity, you can have tumor immune heterogeneity, and the idea is to put the two together. Last disease I'd like to sort of emphasize is to do with the lymphoproliferative disorders. So leukemias and lymphomas have always been kind of on the leading edge of new cancer treatments. And why is that? Well, it's because they're one easier to study, because you can obtain, a lot of times you can obtain your blood and study leukemia cells from that, and lymphomas you can take lymphocytes tend to grow in culture pretty easily, so you're able to take a biopsy and grow in culture and study it that way. Well, there's a lot of targeted therapies for lymphoproliferative disorders, and more are coming. So all these lymphoproliferative disorders go anywhere from myeloma, chronic lymphocytic leukemia, follicular lymphomas, diffuse large cell lymphomas, acute lymphoblastic leukemia. Those are all B-cell malignancies that are on the same spectrum. And some of these drugs work in the myeloma only, some tend to work in chronic lymphocytic leukemia, and some will work across the spectrum. Like Rituxan is a drug that kind of works across all those B cells because they all have the CD20 antigen on the surface of it. Well, the concept here is that these are some of the newer drugs that are coming out, and that in combination, these drugs, we can omit chemo. So chemo has always been the backbone of treatment for all lymphoproliferative disorders. But now we're finding that you can do combinations of these targeted therapies and get superior results than you do with chemo. And not only superior, we say chemo-free does not have to be more effective than chemo. Single non-chemo agents are active but not sufficient. And we need to develop rational combinations and again, understand the biomarkers for response. That's always a challenge, is to know who's going to respond and who's not. But this is Bruce Cheeson, part of the character. He gives a lecture to everybody. He gets the crowd going. Chemo will be relegated to historical interest, is his prediction. And chemo-free will eventually lead to cure. So he was giving a real pep talk for going chemo-free in the lymphoproliferative disorders. And that may happen. I mean, right now, most of our patients with multiple myeloma get bone marrow transplant. That's kind of become the mainstay of treatment, and it still is today as it was before. But there are a lot of doctors out there who think that with these newer agents, one does not need a transplant in that particular illness in multiple myeloma. So there's some controversy going on. It still remains a standard of care. Why would we want to go chemo-free? Well, chemotherapy has a lot of side effects. Some of these targeted agents, they do have side effects, but they don't have quite as many side effects as the chemotherapy. So it has to do with improvement of, one, optimization of results, and two, quality of life. So I'm just going to spend a minute now talking about how this precision medicine is sort of trying to be studied in our medical practices now in the oncology community. Because it's one thing for me to send a patient for molecular profiling and to treat them according to individually, but there's not a lot of data that comes from that. And so I think what we need to do as a society or as scientists in the medical area is to really have an idea of, is this working or not? So there was a study called the MATCH study that we participated in, our group, in which there were, I'm going to tell you a little bit about the MATCH study. So the idea is to improve access to profiling, provide decision support to help facilitate the planning, provide levels of evidence to support the decision making, and to sustain up-to-date annotation and the implications of the variants. And the idea is to provide information on these variants of unknown significance, to turn them from unknowns to knowns, and then of course to develop more better drugs for clinical trials and engage patients to help achieve this goal. So the MATCH was a trial that took solid tumors, lymphomas and myelomas, and tumors that no longer responded to standard treatment. And they would attempt to match certain drugs or combinations to tumors that have specific abnormalities to treat that particular cancer, irregardless of the cancer type. It's a single-minded trial. Treatments that show promise can advance to larger, more definitive trials. So in the master protocol, there were 40 different treatment arms in this study, with more arms coming, and the genomic testing directs patients to molecularly targeted treatments. Each arm evaluates the activity of that treatment in tumors with relevant mutations, and they're hoping to get at least 25% common or rare cancers rather than breast, colon, lung, and prostate, which are sort of the most common cancers we see. So it was 1,100 sites across the country that were participating in this. And you can see Albuquerque and Santa Fe around here. Unfortunately, this study just closed, so it's no longer available. But I think that there will be a lot of important information that comes from it. And it may not all be positive. We may find that we found all these mutations, and we tried all these targeted agents, and we didn't really achieve the results we hoped to. But the concept is there to try to understand if we can actually treat these mutations and what kind of result we'll get. So, the opportunities in this are education, collaboration amongst physicians across the country, develop guidelines. This is a big question. Can we really reduce costs with these new treatments or not? If we're more specific, maybe we could avoid treating patients with things that don't work or are unnecessary, create better treatments, and then artificial intelligence, I'm not sure we're specialized with that. But I think artificial intelligence is a big thing to cover. This, I think, is a much more complicated slide and probably more realistic. So some of the challenges is trying to get people like me to be educated, physicians, to be able to talk to my patients. And also to understand the expectations. That's a really important thing, because a BRAF positive tumor, for example, a patient comes in with stage 4 colon cancer is BRAF positive. I can't really say this is going to hit a home run. You kind of go into it hoping, but statistically you have to really understand if they have stage 4 colon cancer, you may not expect to really get a cure by any means. The whole idea is to get a nice response and some good quality time ahead. But one also has to keep one's expectations realistic. Also, the same thing for patients. For the patient to understand what the realistic expectations are. This is a real challenge, which mutation to target. I think I addressed that. And the discrepant results of tumor heterogeneity, meaning that which is the true driving mutation of that tumor. Another challenge is how to get treatment and access. The sequence of the therapy, the cost. These drugs are very expensive. Finally, to identify who's going to respond, the toxicity, the prevention, and the non-responders, what are the problems? And I think I tried to mention that at the very beginning. All of this really thus far has been talking about the genome, the DNA mutations. But there's so many other factors that are involved in the tumor, including the microenvironment, the microbiome, absorption, metabolomics, genetic complexity, and heterogeneity. So there's a lot of reasons why patients don't respond. So that's kind of the summary of the talk. I do have a couple of improvement objectives again, just to understand the goal is to understand the testing, the history of how we got to where we are, examples of how it's being used, and then to look at some of the challenges and opportunities. I do have a couple, if you want to read further, there's a fascinating book called The Emperor of All Maladies. Actually, who in this room has read Emperor of All Maladies? There are people who've read it. So it's, it really talks about the history of cancer treatment to today. And it's, and he's kind of a fan of this whole precision targeted therapy. He kind of says that as a future. He does a good job of it. This is a book that was just given to me by a patient a few weeks ago, and I happened to read it, called Tripping Over the Truth. And he too goes through the history of cancer treatment, but he kind of is more interested in the metabolic area of cancer and the whole concept of oxidation and fermentation and how to attack cancers in other ways, thinking, because he really feels that this whole genomic molecular target therapy is going to be very limited in the future, and we need to look at other ways to approach cancer. And so he, for example, is a promoter of the keto diet, or using low sugar to get the, because he feels that a lot of these cancers are driven by fermentation, which uses that glucose. So if you deny the cancer sugar or glucose, then you can cause the cancer to regress. And he shows examples of that. So there, it's another historical perspective, but it also kind of creates one, allows one to sort of look at, say, hey, maybe this isn't this precision medicine the way it's currently defined, isn't the only answer. We also need to look at other places. That's it. Thank you. So I think it's a question and answer. And I'm going to put on my glasses. Any questions?
Okay, would somebody collect the cards if you have questions? By the way, there are some ramps out there that came late. If you didn't get one, you can get one afterwards here.
Okay, I got a couple questions.
Amazing. There's some more.
So once a specific cancer cell is identified, how does the drug kill the cancer? So, well, there's a lot of ways to kill a cancer. You know, chemotherapy just basically kills the cancer by preventing the cancer from reproducing. So it just targets the DNA production. But and a drug like tamoxifen or a hormone drug doesn't really kill the cancer. It makes the cancer go dormant. It sort of makes the cancer stop, goes to sleep in a way. So not all cancers are killed by the drugs. These targeted, this precision medicine treatment, a lot of times just turns the cancer cell off at the growth. It tells it to stop growing. So it may not actually kill every last cell. It might just make the cancer go dormant. I hope that answers that question. It's not all about killing cancer. I mean, testicular cancer, we basically kill all the cancer with chemotherapy, and we get, you know, a 95% response rate for chemo. But not all cancers are being killed by this precision medicine approach. Are there any current targeted therapies for neuroendocrine tumors? And so, small cell lung cancer is a neuroendocrine tumor. It's a high-grade neuroendocrine tumor. And these checkpoint inhibitors that we just discussed are being used in small cell now in some various trials with some success. And then I think, as targeted mutations that one can find in the neuron of the tumor, there can be some targeted therapies there. I should mention in the low-grade neuroendocrine tumors, like carcinoma tumors, metastatic livers, that there's a new FDA-approved approach using radio-labeled pharmaceuticals, a drug called statin analog. And so that is kind of a targeted radiation bomb against that tumor, that particular neuroendocrine tumor. Those are for the low-grade carcinoids, and then good for the high-grade small cell lung cancers. There's sub-treatments. Does Medicare provide coverage? So, good questions. That had to do with that. If it's on a clinical trial, Medicare provides coverage because Medicare has a mandate by Congress to cover all clinical trials. As far as some of these other, but typically Medicare only covers FDA approved treatments unless it's on a clinical trial. So that's one of the challenges that we have. One might be able to get authorization using these community-based tumor boards to authorize a drug to be approved. Can I address the cost of precision medicine? And is it realistic that it will be accessible to all? So the answer to that, in my heart of hearts, is that it's not realistic that it's going to be accessible to all, but I think it will be accessible to individuals that have particular driving mutations that respond. But I've been practicing oncology for 28 years now, and the cost of oncology drugs has been growing at a logarithmic rate. And it's just, I really worry. And not necessarily because the treatments are that much better. We're not, you'd like to think you're really hitting a home run. We are hitting individual home runs at times that are very exciting, but treating a whole population, I can't really say what made the major breakthroughs in oncology that is promised with this precision medicine. So that's a big question for me is the cost. And the pharmaceuticals, because they would sell you, they're very good salesmen, as far as, wanting this drug to work for everybody, because they're making megabucks right now on this. It happens that all these pharmaceutical companies make 90% plus of their income in the USA. If they go to the other parts of the world, including Europe and other developed nations, access to these drugs is not as high as it is here, nor is the cost. So they oftentimes, in a country like England, will, for a drug like Rituxan, say, okay, this is what it's going to cost in our country, and they'll negotiate with the pharmaceutical company. That's not being done here in the States. It's wide open. Pharmaceutical companies can charge what they think the drug's worth. And that's how it's done. I hope I answered that question. What is that question? Do I find that cancer tumors can mutate, change in response to anti-cancer agents, chemo or not, i.e. like the flu? And the answer is yes. That's the tumor heterogeneity. So cancer cells themselves are mutating all the time, and if you find another mutation, it makes that cancer behave differently, it will. So it does respond. I mean, it doesn't become resistant to chemotherapy all the time. It doesn't maintain its responsiveness. So, for example, a person with breast cancer, the stage 4 breast cancer response, that response may last a year, may last 2 years, but it's not going to last forever. The cancer will become resistant. Cutting off blood supplies is still in use, especially for liver disease, liver tumors. We still embolize tumors in the liver. And I have contacted pharmaceutical companies who have provided drugs for free for my patients off-label. So what they'll do is they'll try to build the insurance company. If they can't, they'll just give the patient the drug. So that has off-label. They would prefer to do it under the auspices of a clinical trial, but not necessarily. But I have done that in the past, not recently. Future of a precursor med for prostate cancer, and is the medicine med terribly expensive? something terribly expensive. Prostate cancer, we kind of have a limited number of drugs that we're using right now. We have the chemotherapy drugs, and then we have our hormone drugs. I haven't heard of a lot of new exciting things in the prostate cancer milieu. I will pay attention to that, but I don't know. I know some of the newer drugs we use for prostate cancer, like Xtandi and flutamide artery stents. So the 3 NCI-MATCH sites in New Mexico were basically through the University of New Mexico, because all the clinical trials in New Mexico are done through UNM. So our group in Santa Fe is one of the satellite matches at the UNM. So we enter our protocols through the UNM system, and then UNM also has a branch in Las Cruces. So they run the Las Cruces Hospital down there in Memorial. So those are the 3 sites in New Mexico. What is the reason that colorectal cancer does not respond as well as other types of cancer? So I really think that we're getting colon cancer is not a super fast-growing tumor, but we are getting a better understanding. So, for example, these immune checkpoint inhibitors, I think, are coming from colon cancer. So I think the Opdivos and the Keytrudas and things like that, I think they're going to have a role, personally, for colon cancer, because they have a lot of colon cancer. The MSI test, the microsatellite stability or instability, was first recognized in colorectal cancer, but first it was Vogelstein at Johns Hopkins. And that's kind of where that's been translated to different tumors. But they found that the very unstable tumors respond to tumor checkpoint inhibitors. These checkpoint inhibitors. Well, I think that that's going to happen with colon cancer. I think we're going to be able to identify a subset of colon cancer that's going to respond to immunotherapy. But it's not completely standard of care at this time. So it's, we're still limited mostly to traditional chemotherapy for colorectal cancer. Liquid biopsies. Does one know if the hospital in the Anderson does these biopsies, or does the patient have to ask for it? No, anybody can do a liquid biopsy. There's about 5 companies out there that are doing it, and you send it to those companies. We actually have access, our patients here in Los Alamos can have liquid biopsies. So I put a little form out there on Caris, the target mouse study, that MI profiling. That's the main company that we're using for tumor-based biopsies, but there's another very similar company that we do liquid biopsies. I'll be honest, I haven't done that many liquid biopsies. I've only done it with patients that I can't get tissue on to do a solid tumor biopsy. Because I think that the tumor biopsies have a higher success rate in getting yielding an answer. Sort of whoever answered that question. But yes, liquid biopsies can be done by anybody, including MD Anderson. One thing about MD Anderson of interest is that I may send my patients for molecular profiling to one study called Caris. And in the East Coast, I like to use this company called Foundation One. So there's about, there's maybe 8 different companies that are doing these molecular profiling. Well, MD Anderson has their own molecular profiling. So if one goes to MD Anderson, you're going to get their profiling. So they have their own test that they like to do. I can't say it's better or worse than the, Foundation One or Caris. I think they're all pretty good. But I can't tell you they like to do their own. Can you comment on thyroid cancer that is not limited to the thyroid area, cancer cells in the neck tissue or other body areas? Again, thyroid cancer tends to be a very slow-growing cancer. Even without treatments, patients can live very long for most thyroid cancer. So they have a favorable natural history even in the stage 4 setting. But unfortunately, we don't have a lot of great treatments. We use I-131 radiation a lot, and we'll use focal radiation to spots. Chemotherapy has not hit a home run with thyroid cancers. That means that there's a few different kinds of thyroid cancers. The anaplastic thyroid being a very bad actor. think that, if one had a bad thyroid cancer that was being aggressive, that might be a good candidate for doing this molecular profiling to see if there might be some targets to consider these targeted agents. Do countries share their findings in Israel? Absolutely, and we do work together. So I'll be honest, a lot of the new drug development is being done in Europe or in South America, just because some of the clinical trials have more flexibility. And the Europeans happen to have a very good network of clinical research universities that like to work together. So a lot of the drugs that we're currently using have been developed in Europe or in some even in South America, because and they all come to ASCO. This conference I was at was over 50,000 people, and it was just unbelievable how many people were there, and over half of them were from out of the country. So it's a broad spectrum, way over there. I hope that's satisfactory. If there's any more
other questions?
Yeah?
There's something that you said that when they're typing a tumor, that they don't need the consent of the patient. What's the significance of that? And also, could you define checkpoint inhibitor and chemical?
Yeah, so the first question was, when I meant with consent, like when one does a clinical trial, one has to consent to enter that trial. But when one is just testing a tumor for a particular mutation, it's not a germ, it's a somatic mutation. For example, if I have a woman with hereditary breast cancer, I would probably get her consent, just test her for her family genetics, to test her for the germline mutation. But for somatic mutation, because it's not hereditary, it's just an individual tumor, we're just looking for treatment options. And so there's really no sequelae or consequences.
Getting the consent holds things up, whereas with
I'll be honest, I ask everybody's consent, and I document it, but no. I may not get a signed consent, but but to send the test in, I don't have to have a patient's signature on the test.
and then checkpoint inhibitor.
So checkpoint is the two main targets right now are PD, which is the program. Yeah, it's a molecule on the surface of T cells called program death. It allows cells to die. So if you inhibit the inhibitor, it's a checkpoint inhibitor, it allows that to kill the cell. It allows a T cell to kill the cell. It doesn't turn it off. So that it's a checkpoint. So it tells the T cell, okay, we're going to not kill the cell. We're not going to. So it unleashes your immune system. So the checkpoint inhibitors are like taking your race car and taking the governor off the brake and letting it go as fast as you can possibly go. So the problem with these immune system treatments is that they cause autoimmune diseases. Because they unleash your immune system. So patients can get autoimmune thyroiditis, autoimmune hepatitis, autoimmune pneumonitis. So it really unleashes the immune system. So that's the consequences of checkpoint inhibitors. Because they unleash the immune system. They unleash the inhibitor. They take the governor off the brake. That's a simple way. So metabolism has to do with like the Krebs cycle, oxidation of the cell, how the cell survives. And they found that cancer cells tend to work more with fermentation rather than using the oxidation system. So cancer cells have different metabolism than normal cells. And that's that whole second book that we're talking about. It's called Tripping Over the Truth. Thank you all for coming.